Good afternoon. We're very pleased to bring this webinar to you today as part of Maternal Health Awareness Day. The title of our program is Integrating Post-Birth Warning Signs Education and Practice into Emergency Departments and Home Health Agencies. My name is Robin Dioria, and I am the CEO of Central Jersey Family Health Consortium. For those of you that aren't aware how Maternal Health Awareness Day in New Jersey came about, I'd like to share with you the story. It actually started with the birth of a little boy to Tara and Ryan Hansen back in March of 2011. Tara was a 29-year-old New Jersey resident. She was a special education teacher, and Ryan and Tara had actually been high school sweethearts. This was a baby that was very much looked forward to by family and friends, and unfortunately, there were tragic results to her pregnancy. During her postpartum period, Tara did not feel very well. She shared that with family. She shared that with her healthcare providers. And no one really heard what Tara was saying. And unfortunately, 6 days after giving birth to her first child, she died of an infection that went unnoticed and uncontrolled. Tara's husband, Ryan, then created the Tara Hansen Foundation in 2012 with the sole purpose to raise maternal health awareness and to improve communication between patients, healthcare providers, and family members. The name of the campaign that he began was called Stop, Look, and Listen. And at that point, the maternal safety campaign was begun. It actually was through collaboration between the Tara Hansen Foundation, Rutgers Medical School, Rutgers Robert Wood Johnson Medical School, as well as representatives from the New Jersey section of the American College of OBGYN, of the New Jersey section of the Association of Women's Health, Obstetric and Neonatal Nursing, as well as the New Jersey section of the American College of Nurse Midwives, who came together to actually think about ways in which to have this awareness campaign be accepted by not only the healthcare community, but the community at large. We felt that at this point, we really needed to have an organized way to share this message. And we were fortunate enough to have State Senator Joseph Vitale join us and help us write legislation so that an annual day of recognition could be formed. It was at that point that in 2017, a joint resolution proclaiming January 23rd, that's 1, 2, 3, of each year be noted as Maternal Health Awareness Day. We believe we're actually the first state in the nation to make such a significant statement about the importance of maternal health and recognizing the need to address maternal health and mortality issues at the local, state, and national level. Ryan has spoken throughout this country in regard to maternal mortality and the need to raise awareness of maternal health issues. And we are very fortunate to have had his foresight of both him and his family in not only forming this foundation, but really to spearhead the work that's being done in New Jersey, as well as other states now that have actually taken this information that will share with you and put it throughout their state. The tag that you see on your screen now, the link, actually will provide you with a downloadable toolkit for Maternal Health Awareness Day that includes a PowerPoint presentation that you can actually use and modify to make it specific to your particular facility, flyers, posters, brochures. There's even a t-shirt design that many hospitals and community health centers, as well as other community-based organizations, have taken to make designs or t-shirts for their staff to wear on Maternal Health Awareness Day and throughout the week. We also included sample social media posts, and one that you may have seen this past week that has been posted by the Tara Hansen Foundation really speaks to the one goal that our campaign has. And this is the Stop, Look, and Listen campaign. And that is to raise the standard of care for all mothers throughout the birth process. The campaign is twofold. There is a portion that is very specific to healthcare providers that really emphasizes the need for open communication between patient and provider. And if a patient comes with a complaint or with a concern, that the healthcare provider literally stop what they're doing, listen actively to what the woman is saying, and to look at her while she's saying this, and to really have a conversation. And the portion of the campaign that is focused on the community is really one to have women feel and to feel empowered, that if they have a concern, to bring it to their family, bring it to their healthcare provider. And if they don't feel like they're being heard, then they need to persist or possibly go to someone else, another family member, a friend, someone who will, with them, take their concern and escalate it to the point where they may actually need to go to the hospital. We hope that you'll use this toolkit in your facilities. Use the hashtag if you have social media available to you, hashtag 123 for moms, and that has been associated with, and you will see that if you are on Twitter. There are sample Instagram pages as well as Facebook frames that you can use available in this toolkit. And we truly want you to take this, use it, share it with others, so that the more people that we can share this information with, the better. Today's webinar actually takes this message one step further. And you'll see and hear a lot of what I just shared with you, of what started with this Stop, Look, and Listen campaign, integrated throughout the post-birth warning signs education. So we hope that you enjoy today's webinar. You use this information with your patients, with family, with friends, anyone that you feel that this could have a positive impact. Because every one of us has the power to make the difference for women, and particularly for women in New Jersey. So thank you for taking the time. We truly appreciate your participation in this webinar, and we hope that you're able to take this information and share it. It is now my pleasure to introduce Lori Nabin, who is the Director of Professional Education and Community Engagement at Central Jersey Family Health Consortium. And thank you.
Thank you, Robin. Our speakers are Dr. Trish Suplee, an associate professor and division chair at Rutgers University School of Nursing in Camden. Dr. Suplee has been a nurse educator and researcher for the past 25 years, focusing on maternal health. She has published extensively on this area of interest, and during this time, she has been involved in conference planning and has spoken nationally on several maternal topics. Joining Dr. Suplee is Dr. Suzanne Spurnell, who is the Vice President of Women's Services at Robert Wood Johnson Barnabas Health. She's been working in women's health services in the inpatient setting for 24 years and the outpatient setting for 2 years. She's a board-certified advanced practice nurse and certified as an inpatient obstetrics registered nurse. She is also a policy advocate addressing women's health needs as a care continuum. It is now my distinct pleasure to introduce Dr. Suplee.
Hello. We'd like to thank you for the opportunity to speak on this day in New Jersey, Maternal Health Awareness Day. It is the first state to actually acknowledge that maternal health is a major issue in our country. Today we're going to be presenting on post-birth warning signs education and practice, looking at emergency departments as well as home health agencies. So by the end of the presentation, the participant will be able to describe the current state of maternal mortality and morbidity regarding rates, leading causes, and disparities, examine postpartum discharge education best practices, summarize how collaborating with other types of providers and services, including home health agencies, can contribute to improved maternal outcomes, describe the integration of a postpartum triage protocol in an emergency department, and finally identify challenges and lessons learned when incorporating new obstetrical protocols in emergency departments. So for an overview, maternal mortality rates are used to express the ratio of maternal deaths to live births. In the U.S., maternal mortality ratios have been on the rise and have remained at an elevated state for several years. The most recently reported rate by the CDC is from 2016, and it reports there have been 16.9 maternal deaths for every 100,000 live births. Here you can see that mortality rates in the U.S. have been fairly flat over the past 10 years, albeit higher than other developed nations, as reported by the World Health Organization for 2017, maternal mortality ratio estimates. So just a few reminders of definitions that we're going to be using throughout this presentation. Pregnancy-related death is a death of a woman while pregnant or within 1 year of giving birth from any cause related to or aggravated by the pregnancy or its management, but not from an accidental or incidental cause. Maternal mortality ratio is an estimate of the number of maternal deaths to live births, and that's basically what you're taking a look at now. Maternal morbidity is acute or chronic illnesses related to pregnancy. And finally, the term preventability is, could these deaths have been prevented? And basically, the CDC is reporting that about 60% of maternal deaths could have been prevented. With regards to timing, according to the most recently reported data from Peterson and his colleagues in 2019, the majority of maternal deaths occur in the postpartum period. All pregnant women are at risk for developing a postpartum complication due to the physiological changes that occur with pregnancy. In the U.S., 52% of pregnancy-related mortality occurs in the postpartum period. And in New Jersey, about 68% of deaths occur in the postpartum period, which is extremely problematic. So the top bullet, you see the timing, where 31% occurs during pregnancy, 17% on the day of delivery, and then 52% is what occurs in the postpartum period. And these are the national rates. When you go to the next bullet, it's the leading causes. And the leading causes of pregnancy-related deaths in the United States are cardiovascular conditions, non-cardiovascular medical conditions, and infection and sepsis. Cardiovascular deaths are even higher if you combine cardiac conditions with cardiomyopathy. Around the world, the leading causes are hemorrhage, infection, and hypertensive disorders, as reported by the World Health Organization. The next circle you see race, ethnicity. Racial disparities do exist in maternal outcomes. As you can see, Black African American women experience greater rates of maternal mortality compared to other racial ethnic groups. In addition, Black African American women are at greater risk of developing cardiovascular conditions, especially in the late postpartum period after 42 days, compared to other groups. In New Jersey, we have racial and ethnic disparities as well, whereby it's actually higher than what the CDC reports, and African American Black women are actually 5 times higher, which has been reported. When we look at age in general nationally, we see that it's almost equal here, with those greater than 35 being at 48.1%, less than 5, 51.9%. However, some studies have reported that most deaths do occur in women who are above 35. Since most deaths do occur in the postpartum period, breaking down the causes of deaths can be helpful when creating interventions and providing preventive measures. ACOG has suggested that all women should be contacted within the first 3 weeks of delivery, followed by a more thorough assessment later in the postpartum period. However, this practice has not been initiated nationwide. The U.S. has taken the lead on following women out for 1 year, compared to the traditional 42 days as reported by other countries. This time frame has provided clinicians with valuable information that can be useful in providing interconception care and follow-up care for those with risk factors. So as you can see on this chart, when we divide up in the postpartum period and we look at that specifically, the first week postpartum, most deaths are from hemorrhage, hypertensive disorders, and infection. From days 7 to 42, it switches to infection, cardiovascular conditions, and cerebrovascular accidents or strokes. And then after the 42-day period out to 1 year, we have cardiomyopathies, cardiac conditions, and non-cardiovascular conditions. So what are some strategies that we can do to decrease maternal mortality rates? Well, first of all, we have to look at the factors and when these factors occur with regards to maternal health. So when exploring and creating strategies for preventing maternal mortality, there are actually 5 levels of care that can be addressed. In a study done by Suplee and Bingham, nurses were surveyed about their knowledge and teaching of maternal complications. We found that the majority of nurses were not up to date on the rates of timing of maternal mortality and did not always provide comprehensive discharge education to all women. Hence, if providers reported not providing this information, many women were not receiving comprehensive messaging. Therefore, researchers and clinicians can focus on improving patient education in the patient's family and provider level. So that was just one example of using a level to actually guide outcomes. And again, as you can see, it also crossed over into the provider level, because we also have to make sure that all our providers are providing the same message. When we look at education in general, we tend to focus on discharge instructions of women and what they receive after they deliver. However, there are several touch points throughout a woman's care that can also provide vital information. So as you can see, we could actually start prenatally with prenatal providers, educating doulas and childbirth educators, just like we do with some of the postpartum issues before a woman delivers. Postpartum providers are especially key, followed by home health and outreach providers who are actually providing postpartum care and possibly home visits, pediatric emergency department and primary care providers as far as continuity of care. We also know that women will bring their infants in for normal visits to the pediatric department, so therefore that is another ideal place. Emergency medical technicians who actually will be in correspondence with women who may need their services. Also, we have to jump over to nurse and medical educators who are being educated on what information they all should provide. And finally, society is getting the word out on the importance of maternal morbidity and mortality and what we can do to prevent these conditions. In one cross-sectional study by Suplee, Bingham, and Kleppel, 372 RNs completed an electronic survey with the purpose to assess postpartum nurses' knowledge of maternal morbidity and mortality and to learn more about the information nurses shared about how new mothers can identify potential warning signs of postpartum complications. We found that 46% of nurses were not aware that maternal mortality rates had been increasing in the United States, and the majority did not know that these deaths were mainly occurring in the postpartum period. This table reports on the likelihood of discussing all topics with women prior to discharge. And as you can see, the nurses reported most likely to discuss postpartum depression, hemorrhage, and infection. But as you look down on the other possible conditions that can develop in the postpartum period, they weren't more likely to discuss them. And in fact, when you look over to your right side, there were many times that they only discussed it if they thought it was relevant. So again, it's very problematic that we have to get this message out. A1 Save Your Life teaching tool is being used around the country by nurses and patients. This tool can be found on A1's website, and you can contact A1 to use in your organization at no cost. It has been translated into 3 different languages. This tool was developed by a team of nurse experts following focus groups with nurses caring for women at the bedside. And as you can see, there is a time frame for assessing signs and symptoms. So again, it spells out post-birth. P for pain in the chest, which would obviously be connected to possibly pulmonary embolism or cardiac conditions, obstructive breathing or shortness of breath, seizures, thoughts of hurting yourself or your baby. We instruct women to call 911 or go to the emergency room if they are experiencing any of those. Bleeding or soaking through 1 pad an hour or blood clots the size of an egg or larger, incision that is not healing, red or swollen leg that is painful or warm to touch, temperature of 100.4 Fahrenheit or higher, and finally a headache that is not relieved even after taking medication or associated with visual changes. We do know that many women present to the emergency room complaining of the worst headache of their life, and that indicates, again, something that should be very carefully looked at with regards to the potential for preeclampsia. If women are experiencing these, we tell them to call their provider right away. We always inform women to trust their instincts. Always obtain medical care if they are not feeling well or have questions or concerns. We also encourage them to say that they have delivered or they have been pregnant within the last year, because it may indicate to the provider that they need to look a little bit closer about what the patient may be complaining of. As I said previously, there are several provider types that interact with women that we can provide postpartum education to regarding assessing for potential complications and informing them of what to do if they experience them. In New Jersey, the post-birth warning sign tool is being used by several organizations that utilize a home visiting model. Home health workers, educators, and even doulas have attended workshops to learn how to educate women about postpartum maternal morbidity and mortality. These programs have reported very positive experiences with using the tool. So for example, the Southern New Jersey Perinatal Cooperative, the Camden Healthy Start, and the Family Support Service programs have received information and education, and the Central Jersey Family Health Consortium, the Healthy Women, Healthy Families, and the Community Health Workers and Educator programs have also received the same. When trying to incorporate education into the community, it is vital that the members understand the impact and how they can contribute to reducing rates of maternal mortality. It begins with an initial contact, a reach out. At that point, you want to collaborate. You want to then continue to educate, roll out the program, get some feedback, and then evaluate before you start again. So it's a continuous circle. So this proposed circle has worked with those two collaborations that I've talked about on the previous slide. Now my colleague will discuss what emergency departments can do to enhance the care they provide to postpartum women.
Addressing the critical issue of improving maternal health outcomes and eliminating maternal health disparities has been an RWJ Barnabas Health System priority. Last year, we launched an important initiative in all of our emergency departments to reduce maternal morbidity and mortality. The heart of the initiative is a single question asked of female patients of childbearing age immediately upon arrival. Have you had a baby in the last 42 days? A yes alerts the care team that this is a patient who may require immediate attention and that protocols for care may be different than for a woman in the general population. I want to share a little bit about our journey from where we developed the big idea to its full-scale implementation. In the summer of 2018, our internal OB collaborative, an interprofessional leadership team representing all 8 of our birthing hospitals, discussed areas where opportunities may exist to extend our influence to impact outcomes beyond the 4 walls of L&D and postpartum. The most obvious choice, knowing that the majority of maternal adverse events were occurring in the days, weeks, and months following birth, was the emergency department. Physician and nursing leadership from both OB and the emergency department met and discussed the situation. Both national and state data was discussed to ensure a broader understanding of the scope of the problem. Media stories about missed opportunities and bad outcomes were shared, and then the discussion turned to ways we could partner on an initiative to better identify and expedite the care of women who present to the emergency department who may be experiencing a life-threatening complication. As you can imagine, and what I learned in great detail, is the number of competing priorities for emergency department physicians and nurses. Similar to labor and delivery, the emergency department is a fast-paced environment with unpredictable volume and acuity. So in order to foster quick adoption and promote equitable care, it was suggested we automate whatever process we were going to develop as much as possible. It was then that we asked our information technology team to partner with us. We again provided the background, including the blind spot for frontline providers if they're not aware the patient had recently given birth. We then relied on their expertise to develop an electronic process with the information we gave them to help reduce some of the burden for the frontline staff, but keeping our goal of identifying postpartum women top of mind. The result was a trigger and alert system built into the EMR. In simplest terms, this alert is triggered through an interface that recognizes this patient has had an obstetric admission for delivery in the prior 42 days. And each time someone logs into the record, the alert fires, reminding everyone the patient recently had a baby and the symptoms this patient is experiencing may require expedited specialized care. For example, a headache. Headaches can be a symptom of many benign causes such as fatigue, stress, and dehydration, and it can easily be dismissed or minimized as normal by a new mom or her family. It may also be underappreciated by providers unfamiliar with symptoms of something much more serious known as postpartum preeclampsia. Delays in recognition and treatment of preeclampsia can result in life-threatening complications such as stroke, and hypertensive disorders of pregnancy are among the leading contributors to pregnancy-related deaths worldwide. The second way the alert can be triggered is through a simple question that was added to the emergency department triage form. We added this question because not all women will return to the same hospital where they gave birth, and the hospital where they present may be in a different healthcare system because it's closer to their home. It was important to us to have a safety net in place
so all postpartum women would be identified. The question asks all women between the ages of 12 and 60 if they've had a baby in the past 42 days. If the answer is yes, that yes response will trigger the alert and add a list of symptoms. We have identified over 100 women in the past year who presented to one of our emergency departments for any reason within 42 days of giving birth, but had not given birth in one of our hospitals. As a starting point, I would encourage everyone listening to share the national and state maternal health data with their emergency department leadership. It becomes the heart of a very compelling argument to make practice changes to improve maternal health outcomes. There are many data resources online, including the latest report from the CDC, and the New Jersey Department of Health also has outcome information on their website. Use this data to start the conversation and to begin building momentum around a collaborative effort and a better understanding as to why the timely recognition and treatment of postpartum women is imperative to impact both maternal morbidity and mortality. OB teams should provide their emergency department teams with current practice guidelines for pregnant and postpartum women and should offer to help educate emergency department teams about the differences in care between this unique population and women in the general population. Don't make assumptions that healthcare providers outside of OB are familiar with all of this information. Improving quality of care for pregnant and postpartum women is a multi-dimensional effort and requires dynamic partnerships between women, healthcare providers, communities, and policymakers. The time is now to come together and use evidence and innovation to improve quality of care and eliminate preventable maternal morbidity and mortality.
Thank you very much for that presentation. When we reviewed your slides, a number of the people on the planning committee had some questions, and we're sure people viewing this webinar may have some of the same questions. So if it's okay with you, Dr. Spurnell and Dr. Suplee, if I could ask some. Dr. Spurnell, specifically, how did you engage the emergency department?
So the frequency of postpartum complications has increased, making it more common for patients to present to the emergency department with symptoms. And I think that the emergency department providers and nurses were starting to see that. And when we approached them about a collaborative partnership to make the recognition and treatment of these patients a little bit easier for them, they were quickly on board with the whole idea. But as I said, with all of the competing priorities in the emergency department, making the process as automated as possible would allow for a quicker adoption and execution of the whole project. Some of the challenges that we initially had were being able to provide the emergency department with baseline data. So when we did a look back of 2018, we were only able to draw a very limited number of cases based on the coding of common complications that are seen in the emergency department, which really told the story that we probably were not identifying these women as often as we should have been. Because when we're looking at numbers for 2019, we're seeing a significantly higher number of women, and it has allowed us to see what the reasons are that women are coming back to the emergency department in that window of time. And one of the most common reasons that women are coming back to the emergency department are for complications of hypertensive disorders of pregnancy, and more specifically, one of the most common symptoms that's listed as a chief complaint is headache. We see a lot of women between days 3 and day 7 returning to the emergency department with a severe headache that's escalated over the prior day or two, and these patients are being readmitted with postpartum preeclampsia. Again, the number of women that actually return with an OB complication is quite small, but the number that return in that 42-day window, which was very eye-opening for me for all cause, is actually quite high, which has led us to look into the reasons why these women are coming to the emergency department when there may be other community resources available, which is telling that maybe we need to be very specific. So initially, we were not aware of that blind spot for providers about these, the different treatment algorithms that we use in OB compared to what they're using in the emergency department. We just assumed that they were aware. So it wasn't until we got closer to implementing the project that we realized that we were going to have to develop some order sets and some specific protocols for our emergency departments in order for them to begin the treatment process for some of these patients, most specifically patients that were returning with preeclampsia. And as the initiative started to become more comfortable in our emergency departments, some of our emergency departments even became more innovative and created internal codes, like you would hear a code blue for an adult cardiac event. They created codes for patients returning to the emergency department that required a quick OB response. In addition, the Joint Commission, beginning in July of 2020, which may make the argument a little bit easier for you to start making some changes in your emergency departments, will be implementing 2 new standards of practice, and one of them is reducing the likelihood of harm related to maternal severe hypertension and preeclampsia. And this does not just include in labor and delivery and postpartum, but it encompasses the emergency department as well. And they'll be looking for things such as procedures for measuring and remeasuring blood pressure, and the procedures to include criteria that identify patients with severely elevated blood pressures. And the thresholds for OB are certainly different than they are for women in the general population that may be frequently seen in the emergency department. They'll also be looking for evidence-based procedures for managing pregnant and postpartum women, and it will include having quick access to emergency medications and being able to speak to the use of seizure prophylaxis and when to get consultations with experts on the management of these patients, and also for the transfer of these women to a higher level of care, because keep in mind, some hospitals don't have maternity care, and some hospitals in our system don't have maternity care. And we had to build in processes for those hospitals for what they needed to do and who they needed to contact if a woman presented to their emergency department with complications of pregnancy-related complications.
Thank you. In the SUPLEE study, did you ask nurses about the specific signs and symptoms they teach women, and what did you find?
Yeah, so on slide 8, we talked about the likelihood of RNs discussing potential complication topics. And what we did in the study is we then broke down those topics to actually specific signs and symptoms, and whether or not the RNs were discussing these specific signs and symptoms with all women. So the responses they were allowed to give were very likely, likely, somewhat likely, not likely, and only if relevant. So to go through each one, we divided them into categories. So for example, cardiac pulmonary embolism, we asked about difficulty breathing or shortness of breath, and about 45% of nurses were very likely to discuss it. Chest pain, about 38%, and weight gain, about 29%. Now, Now, weight gain is problematic in that weight gain can go along with cardiomyopathy. However, most of the cardiomyopathies don't occur until later, almost after the 6 to 8 week checkup. So in the beginning, we're usually not asking about weight gain, and it is a very vague symptom. OB hemorrhage, we divided it into bleeding, saturated, 1 or more pad per hour, and passing clots. And we got a good result with that. Basically, about 98% of nurses were talking about that with women. Infection and sepsis, this category too was high, increase in redness or discharge from incision, temperature greater than 100.4 Fahrenheit, bad smelling discharge from vagina. They were all, again, being discussed. The next couple of categories, however, were not being discussed as often. For example, venous thrombosis, only about 50% were very likely to discuss a pain in the calf area. Redness or warmth of the calf area was about 48%, and swelling of one leg was about 38%. So we do have that area where we can get better. Preeclampsia, eclampsia, hypertension, connecting this with Dr. Spurnell's work, we do see that only about 50% of nurses were very likely to discuss having a severe constant headache with women. Vision changes and swelling of hands or feet was about 47%. Nausea, dizziness, elevated blood pressure, and seizures, again, they got lower and lower as you went down. So again, only about 23% of nurses were very likely to talk about the potential for a woman to have a seizure after she was discharged. And the last category was postpartum depression. And this one, again, feeling depressed, majority of nurses were talking about this topic, and I think the topic of postpartum depression over the last decade has really received a lot of press, a lot of media attention, a lot of research has been done on it, so it almost seems like nurses are pretty comfortable talking about that topic. And then thoughts of hurting the self or baby, about 80% were very likely to talk about this as a potential complication. So what we really did strive to do in this study was to identify implications for practice. And one of the major ones was to encourage women to tell somebody if they were feeling any of these signs or symptoms. Because again, once they told somebody, they were more likely to get and receive care.
Thank you. Still a lot of work to do. Has the CDC suggested any strategies from the data they've received to address maternal mortality and the different levels of care?
Actually, they have. In May of 2019, Peterson and colleagues put out a report from the CDC data. And basically what they were able to do was take what was reported from maternal mortality review committees and then kind of block it off into contributing factors and also strategies to address those contributing factors. So I would highly recommend this article, which is and can be found in our reference list. But when we look at these factors on slide 6, what you're going to find is that they've kind of broken down the factors by, again, the same titles: community, facility, patient, family, provider, and system. And then they basically went through each one with regards to what we can do with regards to strategies. So, for example, in the community, we can, one of the contributing factors that has come up is access to clinical care. So a strategy can be expand office hours, increase number of providers who accept Medicaid, increase availability and use of group prenatal care programs. Another one may be lack of inadequate transportation options, where their recommendation is to strengthen or build systems to link persons to affordable transportation, or provide vouchers for transportation to medical appointments. So again, these are some strategy examples that are listed. When we talk about facility, the contributing factor that has come up is limited experience with obstetric emergencies. So again, implementing obstetric emergency simulation training for emergency department and obstetric staff members would be beneficial. A lack of guiding protocols or tools to help ensure quality care provisions. So again, our organizational settings using, for example, patient safety bundles that have been put out by AIM, implementing systems or fostering communication among collaborative providers and interdisciplinary providers. When we focus on patient and family education, lack of knowledge of warning signs, which we've addressed in this presentation, but also the standardization of education and the mechanism for where we ask the patient to use a teach-back method by the provider to make sure they fully understand the information that's been provided. On the provider side, maybe there's an element of missed or delayed diagnoses. When are we telling women to come back for blood pressure checks, for example, if they are being discharged from the hospital with an elevated one? Lack of continuity of care. How are we trying to improve the transition of communication between obstetrician and gynecologists and other primary and specialty care physicians? And finally, systems. Maybe the inadequate receipt of care. Do we all have policies in place to look at appropriate levels of maternal care? And this is where Dr. Spurnell was talking about the requirements coming out through the Joint Commission. Designing educational initiatives for emergency department staff members or the care of pregnant and postpartum women. And then we could also look at guiding policies and procedures or standards not being in place. You know, there's a lot of research that has been done and also evidence that can contribute to organizations actually building their own practices and protocols and updating their policies. One example is from the AIMS bundle, and it's called the Postpartum Care Basics for Maternal Safety. And you can all access these online. The resources is on the reference list. But it talks about readiness of every woman, provider, and clinical setting. And it outlines specifically what organizations can put in place for their patients. The other column is recognition and prevention, and then also response. So those are clearly outlined in these AIM patient safety bundles. And not only are there bundles for safety for postpartum care, but there's also additional ones for things like mental health and maternity, and also hypertension, preeclampsia, eclampsia.
Thank you. I can see that both of you have done much work to improve the health of women and to reduce maternal mortality. We really appreciate you presenting for us today. Here are the references that were cited. I will leave those up for a few minutes so that you can make notes. We will also send out the slides upon request. You can email me at lnavin, N-A-V-I-N, @CJFHC for copies. The speakers today had nothing to disclose. There was no commercial support for this program, and this program has been awarded 1 nursing contact hour from Central Jersey Family Health Consortium. To receive a certificate, attendees must listen to the entire webinar, complete the online evaluation, which you will receive